Thank you for joining us again for our point-of-care ultrasound lung ultrasound interpretation lecture. We're also going to go over some details about how to evaluate for diaphragmatic excursion, as well as some needle placement and procedures for the lung and thoracic area. So our outcomes for today are to identify the techniques utilized to evaluate lung and pleural ultrasound, which we started a little bit on last week. We're going to also recognize the following lung pathologies, including atelectasis, pneumothorax, pneumonia, hemothorax, and pleurodesis. We're also going to assess the algorithms utilized to evaluate dyspnea with the use of point-of-care ultrasound and describe sonographic technique for evaluation of diaphragmatic excursion and evaluate the opportunities for sonographic guidance in lung and pleural procedures. So when we're working at evaluation of the lung utilizing point-of-care ultrasound, there's some great benefits to this. So it allows for immediate clinical management and decision-making by the practitioner. However, it is very user-dependent. So if you're not confident or comfortable in utilizing this, you can come up with some very inaccurate diagnoses. We know that normal lung is represented with the pleural sliding and A-line artifacts indicating aerated and expanded lungs, as we talked about last week. And so we're going to be utilizing those findings to evaluate the lung this week. We're also going to look for interlobular septa. When we are unable to visualize the interlobular septa, that is actually normal due to the minuscule size of the normal lung. However, if the lung starts to retain fluid, we replace that artifact of our A lines with B lines, which would indicate an abnormality. So physiologically, how this occurs is the fluid is going to fill in the lungs from the septa to the interstitium, to the alveoli, and eventually into the pleura as a pleural effusion. So this changes the appearance from our normal A-line artifact, which indicates that the lung is aerated, and it starts to take on that fluid, and we start to get better propagation through the lungs, which is actually an abnormality. So that propagation and the feedback that we're receiving from our ultrasound creates B lines through the tissue, indicating that there's a lung, that there's some infiltration there. And then finally, if this proceeds far enough along, then it leads to pleural effusion, which we're going to identify as the replacement of aerated lung with thoracic fluid. So as we talked about last week, it's really important to be comfortable identifying the normal lung. So we're going to evaluate it in a couple different ways. First of all, you can see here, over here on the right, that we can see that we have really good A lines coming down from the interface of our parietal pleura and propagating through the lung tissue, indicating that there is air, creating artifact, which in this case is a good thing. We're also able to evaluate the pleural thickness and pleural motion. So while we might use a lower frequency transducer to get the depth here to evaluate the lung artifact throughout the lung, when we go to the pleura, we may want to switch to a higher frequency linear transducer to evaluate just this pleural line. And again, we're looking for motion of that pleural line. While you're doing that, you can also evaluate for pleural thickness. Anything over 3 millimeters of the pleural thickness or any non-uniformity could indicate that there's an issue with the pleura there. As I mentioned before, obviously aeration is going to create the A-line artifacts, so that's one of the most important things we're looking at. And then we can also use what we call the curtain sign at the diaphragmatic level to evaluate, as we see over here, the diaphragm, and then a fully aerated lung would create these A-line artifacts as a curtain sliding down to the diaphragm and back up, and so you would be able to identify that that lung is fully aerated even at the most inferior portions when we utilize this curtain artifact. Okay, so to make this useful, what we find is that ultrasound can be a great addition to a chest x-ray or even a replacement of a chest x-ray in some situations. So When you're suspicious for a pulmonary embolism, a COPD patient, asthma, or not other non-pulmonary causes, we can utilize ultrasound to evaluate the lung field, which actually typically ends up being a little bit more sensitive than your normal chest x-rays, especially on patients that are in a situation where you're not going to get optimal imaging through x-ray. So one of the ways it is able to evaluate a PE is not necessarily looking through the lung tissue and the vascularity there and identifying the PE itself. What we're going to be doing is taking a more indirect approach where they found that the presence of a DVT in a patient that's demonstrating acute respiratory failure actually is an indicator and has a specificity of about 99% and a positive predictive value of about 94% that there's a PE present. Although obviously we're not going to be able to identify the location on ultrasound, it could determine your treatment plan from that point forward. Now, COPD, we can identify changes in the diaphragmatic position as well as shape. And so it can be useful in identifying COPD patients. So some of our abnormal findings that we're looking for and we're going to discuss are pneumothorax, pulmonary edema, pneumonia, and decreased left ventricular ejection fraction. Now, in this case, we're not going to be looking at the heart in today's lecture, but we know with that decreased fraction, we're going to be suspicious of some pulmonary edema. Now that we can identify. So we'll start with the pneumothorax because that's probably one of the most likely procedure or most likely findings you're going to be looking for. So we talked about last week how we're going to be looking for absent lung sliding, and we're going to be doing that at that pleural level. So if we have good lung sliding, we should see what we call the seashore sign. And so with the seashore sign, if we were to take an M mode at the level of the pleural interface down into the lung, as you see here in A, you would see that as that M mode reading comes through right here at that pleural interface, you should see anything distal or deep to that pleural interface with this kind of irregular, almost C-like reading. And that would indicate that that lung is fully aerated and that pleura is sliding. So that would be able to help you eliminate the possibility of pneumothorax. On the other hand, if there happens to be a pneumothorax, utilizing that M mode method, you would again run your M mode line down through the pleura and into the lung field. And what you would see, again, you're going to have air in this region, but you're not going to have lung tissue. And so you'll see the loss of that kind of speckly reading that looks like, waves in the sea. And you'll start seeing this barcode sign, as you recognize here. So in evaluation of our pneumothorax, we're really looking with M mode along with evaluating for pleural sliding to determine if we're getting a seashore sign, which is good, or a barcode sign, which would be bad. So again, when we're seeing those A lines, that does not rule out a pneumothorax because we know that a pneumothorax can be replacement of the lung tissue by air in the pleura. So one of the best ways to evaluate whether there truly is a pneumothorax or not, aside from the lung sliding, aside from the seashore sign versus barcode sign, we can also look for something called a lung point. Now, if you look down here you can see the lung point where the practitioner has evaluated. They see that they have absent lung sliding here at the pleural interface, and yet they find in another region they do have lung sliding. Now that is considered the lung point where you see that interface between the aerated area of the lung and the non-aerated area and helps identify the extent of that pneumothorax. This is the one sign that is 100% specific for pneumothorax and again can help you identify the size of the pneumothorax, which may help you with your treatment plan and any procedural placement of a tube or something like that. The other thing we have to be aware that is going to be happening in our lungs is that we're going to get some cardiac reverberation because of its close proximity to the heart. And the cardiac reverberation is actually a good sign, because if the lung is collapsed, there's going to be no lung present to reverberate, and so you would lose that sign. Whereas in this case, where you see here, they're taking an M mode reading and you see cardiac reverberation in the lung. So you're getting a seashore sign with cardiac reverberation, indicating that that is an expanded lung, allowing the practitioner to rule out pneumothorax. Now, the reason that that lung point sign is going to be so important is that there can be some little pitfalls in identifying a pneumothorax, because some other things can look very similar. So one of the things that we may, in evaluation of the lung, see is this lack of motion of the visceral pleura. Now, most of the time that would indicate to us that there's a pneumothorax, but we have to keep in mind that things like pleurodesis could cause adhesion of that area and create the inaccurate interpretation that there was no pleura expanded at that region. And so in order to really truly determine whether we have a pneumothorax or something like pleurodesis, then that would indicate, that would require that lung point finding. Lung volume loss can also indicate, or can also appear similar to pneumothorax. This would be where you have a complete atelectasis, mucus plugging, or a pneumectomy. Again, you would see that lack of the parietal pleura sliding, and it could be mistaken for a pneumothorax. Again, if you find the lung point, you can differentiate the two. And then reduced or absent ventilation. So the patient just is not, their lungs really aren't sliding. It doesn't mean that they are not aerated. It just means that that motion is reduced or absent. And so because of that, we could mistakenly think that the pleura is, the parietal pleura is not expanded. And so again, that lung point will help you be able to accurately differentiate the two. Now, when we see some of these pitfalls or some of these pathologies that can trick us into thinking that there's a pneumothorax, there are some other ways that we also want to evaluate this. So if we see that the pleura is thickened, it could indicate that there's chronic lung pathology, not a pneumothorax, but that pathology that is preventing the sliding of that parietal pleura. So if we really want to know for sure in the normal lung that it's aerated, we're looking for thin, uniform pleura. And if we have thin, uniform pleura or the absence of any sort of pleura sliding, then that would also be supportive of a pneumothorax diagnosis. So now we'll look at a little bit at our consolidation pathologies, which are going to be basically demonstrating those B lines. So the consolidations could include pleural edema, pneumonia, or congestion, and it's going to be caused by fluid accumulation. And this is where we're going to start losing those artifactual A lines that we are reliant upon to demonstrate that there is air in the lung. So these are caused by fluid accumulation, which is usually a result of a change in hydrostatic pressure. That could be due to pulmonary edema, so therefore some congestive heart problems. It could be due to pneumonia. Now, pneumonia is going to be that infective process that's causing an increased vascular permeability, which will lead to effusion of fluid into the lung. It could also be due, we can also find consolidations due to lung injury or hemorrhage, where blood is accumulating within the lung, creating fluid there. And then it could be due to collagen or fibrotic changes and interstitial lung disease. So normally aerated lung becomes effused. When we see that, we will see a loss of our reverberation artifacts, and we'll see it being replaced by those B lines. And again, that's just standard sonographic principles, that if there's air, we're going to get artifact. If there is tissue that is propagating through, we're going to get transmission and return of echoes. So we're replacing that artifact with image of the lung, which would indicate there's an abnormality. Now, B lines that do not signify consolidations could be isolated B lines at the lung bases that may be seen due to gravity or setting of the a settling of the fluid in that region. And fissures, larger fissures in the lungs can also produce a single B line. So the trick here is we can't just diagnose off of visualizing one B line. The rule of thumb is that you have to see 3 B lines in a single rib interspace in order for it to be a true positive finding. So requirements to characterize a B line so that you're not tempted to call anything being transmittive areas a B line. Again, you have to have the 3 lines per interspace. They should appear ray-like, so they'd be narrower in the proximal field and then expand in the distal field. They're going to be hyperechoic to surrounding areas. They are also going to be very discrete. So, so you'll be able to define a beginning and an end. They're also going to be emanating from the pleural line, never above. If you have something from above the pleural line, then it would be something that is not necessarily in the lung, but is beginning in the soft tissue of the chest. And then with B lines, you're going to see them move with the sliding lung. So as you're assessing the pleural sliding, you're actually going to see the B lines slide with that pleural movement. And they're going to, like I mentioned, extend in the far field of the image. Now, there's 2 different types of lines, E lines and Z lines, which can be confused with B lines. So just make sure that an E line is going to have a very similar appearance, but these are going to arise from somewhere other than the pleural line. And these are associated with subcutaneous emphysema. So they can, if the patient has subcutaneous emphysema, the accuracy of your point-of-care ultrasound is going to be significantly reduced. You may have to go to a different imaging modality to identify what you're looking for. Now, Z lines, they're going to arise from the pleural line, but they do not extend into the far field. So they're usually less echogenic than the pleura, non-discrete, and they don't move with the pleura. These have no pathologic significance, so you want to make sure that you're not calling these as false positives. Okay, now consolidations, we can use point-of-care ultrasound to map the effusions, so we can identify if if the pneumonia is perhaps bilateral or if it's unilateral. We can also utilize it to differentiate diffuse conditions such as focal conditions. So if we have bilateral B lines, you're going to be thinking something that's affecting the entire chest. So that could be like bilateral pneumonia, or it could be pulmonary edema, possibly caused by your congestive heart failures. It could also be interstitial pneumonitis, because that would also affect the whole bilateral lungs. Infections that are affecting bilaterally, acute respiratory distress syndrome, and interstitial lung disease. If we're just finding unilateral B lines, then that could be indicative of malignancy, atelectasis on that particular side, a focal pneumonia, or a pulmonary infarct in the area. So our consolidations are going to have a pretty typical appearance we talked about. So the collapse or effusion of alveoli are going to create an area for propagation of isoechoic to the liver tissue. So we call this hepatization. So if you see hepatization or the appearance that the lung looks like liver, then you have to be suspicious that those alveoli are collapsing or more accurately would be retaining fluid. Another finding is that the basilar area of the lung are often identified more commonly on lung ultrasound than on chest x-rays. So this is what makes our point-of-care ultrasound a little bit more accurate than some of those, especially poorly completed portable chest x-rays. So descriptive terms we're going to utilize for consolidation are alveolar consolidation patterns, and we know that these are descriptive, not diagnostic, because that change in pattern is not unique to one consolidated finding. It's going to be just a piece of the puzzle when you're doing your differential diagnosis. So possible causes of consolidations, which we've already talked about, it could be pneumonia, lung ultrasound has a 93% sensitivity of evaluation or finding pneumonia, whereas a portable chest x-ray is going to have about a 54% sensitivity. Now, chest CT is going to remain your gold standard for pneumonia. However, due to time constraints, inability of a patient to get your patient in, or you just need a quick look to begin a therapeutic process, ultrasound is going to be a really good option for you. Lobar pneumonia is going to look, when we have this finding, you definitely see a significant case of consolidation here. The lobar pneumonia is going to have tissue-like density without volume loss. So you see a pretty expanded lobe of the lung here, and you're definitely getting return echoes from that lung indicating that it is filled with something. And so that's going to be your typical appearance of a very significant pneumonia, such as in this case. Now, non-translobar pneumonia, so it's not going across the lobes, may have something called a shred sign. And here we see a shred sign in this region here, and a shred sign that we see here. And it's just, the shred sign is just a jagged edge on the periphery of the consolidated lobe, and it represents the interface of partially aerated alveoli on the unaffected area, coming in contact with that effused tissue of the affected area. Now, with our non-translobar pneumonia, we may also demonstrate pleural line thickening due to inflammation. And finally, dynamic bronchograms. And so when we talk about dynamic bronchograms, this is actually where you actually can see air moving through the bronchi, and they appear as bright bubble-like findings moving through the bronchi within that consolidated lung. So rather than seeing the normal A lines of your aerated lung that would obstruct our view of what the air in the bronchi, now that we have the consolidation in this lung, it creates a tissue-like appearance, and now our air within the bronchi are going to demonstrate almost a bubbly type appearance of air trying to move through those. And then finally, if this goes on long enough, it's going to turn typically into a pleural effusion, which we'd easily identify. Here's a small pleural effusion here where a little bit of fluid is going to have that anechoic appearance. All right, so atelectasis is another finding which we may come across with your point-of-care ultrasound. So when we're looking at a case of atelectasis, you can often see static air bronchograms where you're going to see air reflective in that lung, in the bronchi of the lung field, but you're not going to be seeing it move dynamically. So it's just going to be static, and air, like we typically describe it on ultrasound, it was going to produce a dirty shadow. So you'll see your B lines, and then you'll see some dirty shadows coming out from where the bronchi are. With atelectasis, you're also going to have a loss of lung volume. Often this is due to a compressive pleural effusion, kind of like you see here. This effusion here is compressing the lung. But what you'll see is that the lung tip is going to move during respiration. And I always think when you see this, it almost looks like a flag or a sail flapping in the wind, because you see as that patient is breathing, you see motion here as that lung is going to float. Now, if you have a mirror artifact, and we talked about this in the first series where we did the physics of our point-of-care ultrasound, when we have mirror artifacts, that is just, it's based off of the properties of how ultrasound transmits through our body. And one of the things it does normally is, especially near the diaphragm, when it's around a large, what we call specular reflector, where there's a nice smooth surface interface, we can have sound come in, interact with, say, some diaphragmatic tissue, get scattered. It'll then hit the diaphragm, and then it will be sent back up to the transducer. Now, when this happens, our system is going to read that as the echo coming from across the diaphragmatic line and being gone for a longer period of time. So it will write this scattered echo above the diaphragm in the lung field. Now, this will not occur. We will not get this artifact if the lung is not aerated. And so for this to occur, if we have a mirror artifact, it would basically allow us to rule out things like atelectasis. Another thing is a negative spine sign. So when you're typically imaging the lung, you're really not going to see the spine, even in this very abnormal lung that we see here, because we've got consolidation, we're not seeing the spine in the far field. But if you look up here, this patient has this significant pleural effusion, and because of the propagation of the sound getting through that pleural effusion, it's actually allowed to interact with the spine, and we can see a positive spine sign. So that would be indicative of an abnormality. And then the other thing we talked about earlier was that curtain sign. So a normal aerated lung, we're going to see A lines coming right up into contact with the diaphragm, and that curtain will move up and down as the patient breathes. And when we lose that curtain, it could indicate that there's either a pneumothorax or there's something else going on that's causing that aerated lung to not be in contact with the diaphragm. Now, abscesses, necrosis, and other complex pleural effusions can also be identified on the consolidated lung. So here we see, like we've talked about, here's a nice, not so nice for the patient, but here's a nice pleural effusion. Here we see that there's a consolidation in the lung, but there's this area of hypoechoic region, which would indicate not just a typical effusion of the lung, but some particular focus that's causing a change in that in the B-line patterns in that area. Here you see more of a complex pleural effusion, and so we have some septations here right against the diaphragm in a pleural effused area. Okay, so the diagnostic process. So your job is not easy at all, but we know that dyspnea is going to be caused by a number of different things. And we know that providing point of care support can actually help lead you to one direction or another of what could be causing that dyspnea. But obviously you're going to have to take the point of care ultrasound findings, consolidate those with your clinical findings and patient history and all of that. So we know that dyspnea can be caused by COPD or asthma. It can be caused by pneumonia, pulmonary edema, or PE. Now, I know from your clinical history of your patient, you're going to have a pretty good idea probably about what's causing their dyspnea, and then you add the point of care ultrasound to that, and it's going to probably support your ideas. But sometimes you're going to want to go through an algorithm to help differentiate exactly where you think that differential diagnosis is going to take you. So you, when you're looking for when you have a dyspnea patient, and you see bilateral B lines on a patient, that's going to indicate more of a consolidative pathology, like congestive heart failure or something like that. If you see a negative, if you have a negative finding, you have nice pleural sliding, seashore sign, A lines, then that might put you, lead you to a different diagnosis. So in the Sony, Arntfield, and Corey book that we've been referring to throughout this lecture series, they have created this fantastic algorithm to help in the decision-making process. So you have a patient with shortness of breath, and you go in and you look and you see that they have lung sliding present. So that would say, okay, lung sliding is present. I have A lines. That would indicate that there's probably not a pneumothorax. So my lung sliding is present. I can pretty much rule out pneumothorax, and then I'm going to start evaluating for consolidation. Now, consolidation, if I have no consolidation, nice A lines, then that would probably rule out your consolidation. But if you have B lines, that's going to indicate that there is some consolidation there, so you'd go on to the next step. Are these bilateral? Are these unilateral? And depending on whether they're bilateral or bilateral or unilateral, it will kind of make you see if this is maybe a more systemic problem or perhaps a more focal problem. Now, if they have consolidation present and you see dynamic air bronchograms, then you're going to see that it's very likely pneumonia. If you have consolidation with no dynamic air bronchograms, then you're going to have to differentiate whether it's pneumonia versus atelectasis. So just kind of a nice little algorithm to kind of help guide you as you get comfortable going through these processes. It'd be a great reference. And then, of course, I'm sure once you're comfortable, you won't need any of that anymore. Now, this is just another chart created by Sonny Arntfield and Corey. So we're thankful for these great discrete pieces of information, which you may want to print out if you're or refer to as you're just first implementing this in your practice. So if we're looking in the lung field and we see that there is sliding of the pleura, there's A lines, that tells us that we have a fully aerated lung, but your patient is still has dyspnea, then you would have to address what's causing that dyspnea. We're also in the lower lobe, we're looking for that curtain sign, sliding of the pleura, and a negative spine sign, as well as mirror artifact. And if you're finding all of those things, you're ruling out a lot of possibilities. So we want to make sure that we're evaluating and making sure that if we only see one B line, then that's not going to count as a B line. You have to, again, see 3 within the inner space. Now, if we have a patient that has pneumothorax, then we're going to lose some of that curtain sign. We're going to lose our sliding, and we're hopefully going to find the lung tip, and that would be indicative of a true pneumothorax. Here we have a patient that is going to have pulmonary edema. So they're going to present, they'd have the dyspnea, and then you start your exam. Now their lungs are going to be expanded, so you should still see that pleura sliding, but now they're going to be consolidated, and so you're going to recognize these 3 B lines. They're true B lines because they're narrow at the top and they ray out distally, and they're continuous from the pleura down all the way to the far field. So when you see that, then you're going to be able to find this bilaterally, since the pulmonary edema would be a bilateral process. Now, if they have pneumonia, again, they're presenting with dyspnea, and you're taking a look, you're going to, if the lung is still fully aerated, or pardon me, fully expanded, you're going to see that pleural sliding, and you're going to see consolidation. So you're going to start getting those B lines, and then you're going to be looking for the dynamic air bronchogram here, and then the shred sign where you have that pneumonia area interacting or interface with the expanded alveoli. And then atelectasis, you're going to see the reduced or absent lung sliding with a pronounced lung pulse from the reverberation from the heartbeat. Then you're going to have consolidation here because they're losing the air out of the alveoli, so they're going to be more consolidated. So you're going to see those B lines. They're going to have to follow all the rules that B lines have to follow to truly be B lines. And then in this, you're going to see static air bronchograms. So you're going to see that dirty shadowing coming out of the bronchi area, but you're not going to see it mobile as you did with pneumonia because they're not moving any air through those bronchi. So obviously you can go through some of those charts and graphs and you know, some of the algorithm more thoroughly, and let me know if you have any questions. But I know this is what you guys do, so so I'm sure you'll be able to implement it into practice with little to no issues. All right, so now pleural effusions, ultrasound is actually more sensitive than our chest x-ray, especially when we're looking at portable chest x-rays on maybe a non-ideal patient. We have 100% sensitivity with pleural effusions of 100 milliliters or greater. We also can often find that we have better differentiation of pleural effusions from atelectasis than on chest x-ray. Again, CT is still the gold standard, but we know all of the pitfalls with CT, you know, the time, the cost to the patient. And so with just this simple evaluation by ultrasound that can be done right at the bedside and give you immediate findings can really be a great tool to help you replace some of that. So it's most easily going to be identified in your upright patient because we know that our fluid or the effusion is going to be heavier than the air, and so it's obviously going to go to the most dependent area. And so having your patient sit up and then scanning at the lower lung margin is going to be your most effective way to find this. We can utilize the 3 points per hemidiaphragm protocol that we talked about last week in the lecture, where you're going to start anteriorly, superiorly in the lung, and then you're going to move more to the middle lobe, move slightly lateral, and then slide down to the posterior point inferiorly, and just past the posterior axillary line. And that's going to be your area of greatest dependence in that posterior costophrenic angle, where most of your effusions are going to be found. So positive findings would be demonstrated as an anechoic fluid superior to the diaphragm. You'll see the diaphragm, chest wall, and atelectic lung. You'll see that lung looking like, as I said, a flag or a sail. You'll see that the lung movement is dynamic as the patient breathes, and that the color and end mode will even show fluid motion. So if you wanted to drop your end mode in there, that can support your finding, but really you're probably going to be pretty sure by just evaluating it and seeing that anechoic area. They have come up with some volume calculations that are supposed to help you determine exactly how much volume is in the area. So if you multiply 16 times the distance between the visceral and the parietal pleura, then that's going to give you a good estimate in milliliters of how much fluid is in there. To get this measurement, you want to measure at the lung base to the mid-diaphragm in long at the mid-capsular plane. And typically, a measurement of greater than 10 centimeters or covering more than 3 rib interspaces will produce a liter of fluid or more when drained. All right, so then we have other ways. Now, pleural effusions, really, when we're seeing them as just an anechoic space on our ultrasound, it's really going to be hard to determine exactly what the makeup of that effusion is. It could be an early bleed or early hemothorax. It could be just serous fluid. It could be a number of different things. So it can be helpful to try and categorize what exactly that effusion consists of. So we can calculate the volume as we talked about. We can also use more of just a general assessment where they describe it as small, moderate, or large. And then we want to evaluate and describe the appearance. So if it's simple, it's very anechoic, and that lung is freely movable in the area. So that sail of the lung will be moving around easily. Now, if it becomes more complex, the complexity just means that it is not just fluid. So it can still be homogeneous, meaning all about the same echogenicity, or it could be a little bit heterogeneous. So this could be hemothorax where the blood is starting to clot and organize, but typically it's going to be exudative. It's possibly chronically transitive, but most often it's going to be found to be exudative. Now, when we start seeing echogenic changes in that fluid, then that would indicate that there's some debris in there, and that would, again, support that it's an exudative or transitive process. So it's something other than just clear serous fluid. And then we can also classify the pleural effusion based on whether it's got septations or non-septated. Now, as a pleural effusion is going to progress, the parapneumonic effusions are typically exudative, as I mentioned. You're going to see more echogenic fluid. It's going to almost look like snow in a snow globe. It will still be mobile, and it'll still be simple, meaning there will be no septations or things like that. When the fluid becomes more infective and it begins to have fibropurulent changes, so developing some scar tissue, more pus in the area, that's when we see loculations and septations start to develop. We lose some of the mobility of the lung field moving. We lose the mobility of watching that fluid move. And you know that as the practitioner, this is going to be a more complex, challenging effusion to drain. So in this case, a chest tube may be necessary, and it's also associated with intrapleural fibrinolytic therapy or surgery to help remove some of that scar tissue that's developing. And then finally, fibroblasts will begin to grow, which will cause thick pleural peel around the pleura to develop and make those probably chronic or persistent fibrotic changes to the lung. Now, another finding you may have is empyema versus abscess. So empyema is going to be a lot more pustulal. pustule thicker, and it's going to cause more compression and atelectasis to the lung. It's also going to result in the thickened parietal pleura. Whereas an abscess, that's going to be more of a contained mass. It's going to have irregular margins, appear non-uniform, and can be hyperemic, having extra blood flow at the periphery, but you're going to be able to differentiate that from a mass in that the blood flow will basically end at the periphery of the abscess, because obviously vascularity is not necessary within the abscess. If you have vascularity within a mass, then you're going to have to be more suspicious that mass tissue is requiring blood flow, indicating that maybe it's more of a tumor in origin. Okay, solid pleural pathology occurs on occasion, and we know that the normal pleural thickness should be 0.2 to 0.3 millimeters. They're very, very thin. And so if you see an area of thickening beyond that area, beyond that range, then you have to be suspicious that that could be a pathology. And again, as I mentioned, in differentiating an abscess from a mass, abscesses will have that peripheral increased blood flow, whereas your masses are going to need the nourishment, so they're going to have internal blood flow. So if we find internal blood flow on an area of concern, that's going to differentiate with a sensitivity of about 89% and specificity of about 100% that this is a pleural pathology or some type of mass. Now, there are some findings, although they're somewhat vague, that would be predictors of a malignancy versus a benign finding. So if you find this mass and then you have an associated pleural effusion, that's going to indicate a malignancy. If the parietal pleural thickness becomes greater than 10 millimeters, also indicative of a malignancy. And if you have the diaphragmatic pleural thickness of greater than 7 centimeters, that's indicative of a malignancy, as well as pleural nodularity. Now, findings of pleural fibrosis. This is when you're going to have fibrotic changes in the pleura. You're going to see a decreased M mode, so you'll have less sliding in that area. You're also going to have thickened, that thickened pleural interface that you can actually measure both on the B mode image, on your regular image, but you can also measure those on M mode as well. And you're going to see that diminished or absent respiratory movement. So like I mentioned, lack of sliding. That lack of sliding could inaccurately make you think that there is a pneumothorax, but once you realize that it's a thickened pleura, then that should lead you to the differential diagnosis of the fibrosis. Solid pleural pathology, some of the most common ones are going to be the mesotheliomas, lipomas, or chondromas. Typically, they're visualized as echogenic or hypocoque structures in the pleural space. This is where ultrasound can get a little bit frustrating. We try and teach ultrasound pathology, and we always say, well, it should look like this, but then you give the caveat, but sometimes it looks exactly the opposite. So, we're pretty non-specific on certain pathologies, and that includes these of the pleural cavity. Now, there are some good ways to evaluate a mass and try and have an inkling whether it's benign or malignant. Most of our benign masses end up being very well circumscribed. They're slow growing. That's a good sign of it being benign. When something becomes malignant, usually they're going to have more thickened, speculated, irregular borders. They can invade into other tissues, and that's going to be indicative more of a malignancy. Mets, often they're going to be multiple. They can have variable echogenicity, specifically because they could be coming from any organ, so they could have different cells making up those mets. So we know that there's no one appearance that we can find. And then mets are going to be associated, as you know, with pleural effusions, and you're going to see them possibly invading other structures, and then you're going to see changes lots of times in lymph node size and things like that. So hopefully that kind of gets you some ideas of not just what the normal chest should look like, but when we are straying from normal, kind of what that could mean. Now we're going to take a minute and evaluate diaphragmatic ultrasound. So diaphragmatic ultrasound can be really useful in evaluating ventilated patients, post-op and neuromuscular compromised patients. It can help a practitioner really decide on the safety of extubating a patient and making some of those decisions more confidently. So when looking at diaphragmatic excursion, the patient is going to be in a semi-recumbent position. And we utilize a curvilinear transducer because we need to get that lower frequency to optimize the depth of where we're seeing that diaphragm. In this case, you're going to take the transducer and you're going to place it in long between the midclavicular line and the anterior axial line, just inferior to the costal margin. So find the middle of your clavicle, draw an imaginary line down the abdomen from that, and then find your anterior axial line, and you're going to go halfway between those two. And then you're going to need to angle the transducer slightly medially and cranially to identify the posterior 1/3 of the diaphragm, as you're seeing right here. This can be a little bit of a challenging image to get, and you almost have to have it perfect in order to get good diaphragmatic excursion, but with some practice and some confidence, you'll be just fine. So at that point, you're going to activate the M mode setting, and you're going to run that M mode line right through the liver past the diaphragm. Then you're going to turn your M mode on, and you're going to see something, hopefully, that looks something like this. So this would be all liver tissue moving up and down, and then this echogenic line is going to represent the diaphragm. And so as you watch that echogenic line move with the patient's breathing, you're going to be able to measure the distance that it's moving or its excursion. Now, excursion measurements can be affected by posture, and then they're going to have specific values that are good indicators. So if in a male, if that excursion is 1.8 plus or minus 0.3 centimeters during quiet breathing, that would be normal. Anything less than that would be abnormal. It should be up to 7 with deep inspiration, and then 2.9 with a good sniff. All of those would be the normals you're looking for. In females, it's going to be a little bit less, so 1.6 quiet breathing, 5.7 deep inspiration, and 2.6 for sniffing. Now, they found, like I mentioned, that this can be really useful in determining if a patient is going to be safely extubated. So they found that if you have 1.1 centimeters of excursion during quiet breathing, that would predict a successful extubation with an 84% sensitivity and an 83% specificity. So it could be a great tool if you're working in the ICU or making those hard decisions. Now, when we're in the same area, we can also evaluate the diaphragmatic thickness. For this, you're going to utilize a high frequency transducer because it's pretty superficial, and then you're going to image at the mid-axillary line in long. The diaphragm is very thin, so it can be very difficult to evaluate. So what you're looking for is this 3-line sign where you see the parietal, or the pleura, the muscle, and then the peritoneum. And you're going to measure between that pleura and the peritoneal measurement, and then that's going to be your diaphragmatic muscle. Now, if you're having trouble getting this, again, it can be taken in M mode. So even if we went back to the last slide and you watched for that excursion, if you just measured the thickness of that echogenic line, that would give you the thickness of your diaphragm. It should measure between about 1.8 and 3 millimeters at the end of expiration. So it's going to allow you to determine the thickness there if you have any concern for that. You can also calculate a thickening fraction where you take thickness at the end of inspiration minus the thickness at, thickness at the end of inspiration minus the thickness at the end of expiration. You divide that by the thickness of the end of expiration, and it will give you your thickening fraction. And fractions less than 20% would indicate that there's some diaphragmatic weakness. Okay, so pretty limited evaluation of the diaphragm, but it can be useful, and especially in that excursion assessment. Now we're going to look quickly at lung and pleural procedures. So you guys as practitioners are probably used to putting a lot of needles in things. We say in the sonographic world, we talk about, finding pathologies and evaluating to the best of our ability. And then because sonography of some pathologies can be very vague in appearance, that most of the time they're going to put a needle in it. So in this case, this is your chance to put a needle in it. So one of the great uses of ultrasound is for needle guidance. It allows for real-time evaluation of needle placement. It's cheap, it has no radiation, and it allows for evaluation of complications immediately. One of the best things about ultrasound is that, is really our ability to evaluate vascularity in real time with you know, with little need for invasive procedures. So in that respect, we really have sort of a hand up on CT. So, you know, if you were to rupture a vessel or nick a vessel and have a bleed, we would be able to find that immediately so you could address it before it becomes a big problem if possible. It also allows monitoring for resolution during the exam to help make decisions. So maybe you want to drain a pleural effusion, you want to see how much fluid was out. You know, typically in CT, you'd have to do a whole nother CT to reevaluate, whereas here you just have the ultrasound transducer on that patient and you can see how much fluid you've removed and know when you want to stop. It also allows characterization of fluid to make determinations. So if you're seeing a pleural effusion that looks very serous, anechoic, simple, you know that thoracentesis is probably going to go very smoothly. If you see something that's very loculated, it might change your decision as to, you know, what gauge you want to use, what kind of catheter you want to use, or if it's even an option to move forward. So one of the main things that ultrasound is used for is site marking. So lots of times physicians will do a thoracentesis or a paracentesis. They're not doing it under ultrasound guidance the whole time, but what they'll do is find their largest pocket, make sure that they're away from, say, the pleura, evaluate the depth that they want to progress to, and do some of those things. So lots of times they're just using this to mark their site and take that information, and then they no longer use ultrasound until maybe after the completion or at the end of the procedure. Other physicians will want to use real-time visualization, so they want to see the advancement of the needle all the way to, say, a biopsy point. Or they want to watch that needle in real time as they do a diagnostic thora to draw back. So there's multiple ways you can do it. If you're just doing for a site marking, usually you don't need any special equipment. If you're going to be trying to visualize the needle maybe on a biopsy or something the whole time, you might want to utilize something like a needle guide, as you see here. So these would be just sterile guides that you can add to your transducer, which allows the needle to stay in position in the line of the sound beam the whole time, rather than try and maintain keeping your needle aligned with the long axis of the sound beam, which can be rather challenging, especially if you're newer to ultrasound. So the equipment that you're going to need could be that needle guide. It would depend obviously on whether you're doing a drainage or a biopsy, and then of course your sterile tray that you're going to want to be utilizing with this. So all dependent upon the procedure that you're doing and what you like to use to make you feel comfortable doing these things. All right, so lung and pleural procedures. So the procedure and the patient position is really going to depend on what you're doing. I mean, you could be doing a biopsy, a thoracentesis, a number of different things. So obviously the patient position is going to be very different depending on what you're doing. So the most important thing is that you're going to optimize the patient comfort. And then positioning for something like a thoracentesis, lots of times practitioners find that it's easiest to be done if your patient is seated, leaning forward on a bedside table, to kind of give you some intercostal expansion to give you a greater area for your needle placement. If it's a critically ill patient, then utilizing that lateral decubitus position with the affected area in the dependent side might be most effective. For chest tube placement, most practitioners like to use supine or semi-recumbent at about 45 degrees. If it's a biopsy, it's just going to strictly depend on what gives you the easiest access to the to what you're trying to biopsy. So when we're doing pleural effusion, or when you find a pleural effusion and want to do, say, a thoracentesis, selecting your site, you're going to want to make sure that you select a site or mark a site that is going to avoid interference with the diaphragm. So in this case, you may want to scan for a moment, kind of watch the distance of that diaphragmatic excursion, help you decide, evaluate for the size of the pleural effusion, and help you decide exactly where you want to go in, and that's going to increase the safety of the procedure. For a pneumothorax or chest line placement, or chest tube placement, excuse me, you're going to want to evaluate for pleural siding, see if you can find that lung tip, evaluate where the A lines are, and before and following the procedure, and Usually you're going to utilize the midclavicular line and advance your transducer cephalically until the most apical area of loss is identified, and that's going to help you determine the size of the pneumothorax and help you determine where you want your chest tube placement. Lung or pleural biopsy, again, this is going to be positioning of your patient is going to be strictly dependent on where that finding that you're trying to biopsy is. Lesions at the pleural line are the only lesions really appropriate for biopsy under ultrasound. And for this, you want to evaluate the pleural sliding and A-lines prior to and following the procedure to make sure you didn't cause any iatrogenic sorts of pneumothorax. Now, needle trajectory, the whole point probably for you of using ultrasound to help in your guidance is to avoid any injury. So you obviously want to plan your needle trajectory so it avoids the diaphragm, vascular, and other organs. And ultrasound's a great tool to use here because we can live time look at the vasculature and see where you want to avoid. Now, this almost seems silly to even say, but you want to make sure that you do not confuse the renal capsule with the diaphragmatic dome. Obviously, this has happened before, or we wouldn't even talk about it, but this should only happen if a patient were to have severe ascites, where you would see that reflective surface of the kidney, the renal capsule, and mistake it for the diaphragm. Again, I can't imagine you having any issues with that, but just make sure if your patient has ascites on top of a pleural effusion, make sure that you really are truly identifying the diaphragm. We can use color Doppler to identify and avoid intracostal vessels to help you with your needle placement so you don't have any bleeds there. The most prominent area that you're going to find those vessels is in the first 6 centimeters lateral to the spine, and then in elderly patients they can be a little bit more random. So utilizing Doppler to evaluate for those prior to marking your spot or advancing your needle is going to be useful. And then pre-measuring the depth that we talked about if you to prepare for how far you want to advance your needle or your catheter. And then, of course, the angle of the needle. If you're trying to scan while you do needle advancement, you have got to keep your needle in alignment with the long axis of the beam. It can be a little bit more challenging because you're probably advancing, especially for most people, we have one dominant hand and one hand that's not so useful. And when you're advancing the needle with your dominant hand, you're scanning with your non-dominant hand, and sometimes that hand does not cooperate. So keeping that needle in alignment with the transducer can be a little bit challenging. You can also have somebody else glove up and try and track the needle for you if that's an option. Sonographers are always happy to help with that. Okay, so lung and pleural procedures, we're going to look at some of the individual procedures, and you guys are the experts in this, so I'm just going to, from the sonographic end, just kind of provide you with a few suggestions that that they share in point of care ultrasound. So we know that ultrasound can be very useful in confirmation of the catheter and guide wire placement. Now, because of the artifact that we see in a pneumothorax, we're not very useful in assessing something in that pneumothorax. So once you've passed, once you've passed a tube through that intracostal interface or the parietal pleura, we're not going to really be of much use because you're going to lose visualization of that chest tube due to the A lines from the presence of air. However, in thoracentesis, the use of ultrasound in thoracentesis has been found to nearly eliminate any risk of iatrogenic injury. So things like nicking the liver or spleen, or creating a hematoma by advancing through a costal artery or vein or something like that, or causing a traumatic pneumo. All of those things can nearly be eliminated by just guiding yourself with ultrasound. We can, they found that effusion depths should be at least about 1.5 centimeters to complete a thora safely. Anything less than that, you're at much higher risk of causing a traumatic pneumo because you'd be working in such a small space. Most often, pocket and placement are identified by ultrasound, and then you don't need to proceed with real-time sonography, and most of the time then you would just follow up at the end of the procedure when you feel like you want to evaluate the fluid levels at that point. Now, if you want to do with real-time sonography, that's great. It's just, again, keeping your hands aligned can be somewhat challenging. If a large volume of removal is necessary, you would be changing out that needle for a catheter using the Seldinger technique. If a small amount of fluid is necessary just for something diagnostic, usually they can just place the needle, take your sample, and then get right back out. For chest tube placements, these will be used for, as you know, pleural infection, hemothorax, malignant pleural effusions, chemical pleurodesis, and pneumothorax. And they suggest using a modified Seldinger technique, except in cases with a hemothorax where there's some large clots. And in this case, you would want to use, they suggest, a large bore 32 French catheter. And of course, that would also be dependent on the time frame you're at. Earlier in the hemothorax, you may be able to remove, the blood's going to be much more liquid. You may be able to remove it more easily. As it's clotted and organized, then it's going to be more challenging, so you might need to move to a different option. You're going to use the same site marking technique as in all the other procedures. So now in a pneumothorax, a Seldinger technique away from the lung point is they find most effective. So identifying that lung point prior to insertion can be very helpful. The parietal pleura is typically only about 5 millimeters distal to the rib. So if you're scanning very superficially, you're looking at the subcutaneous tissue, and then you're getting through the rib interspaces, and then once you can evaluate that pleural line, it's just about 0.5 millimeters distal. So once you breach that, you should receive air return, and that's when they suggest you stop advancement of the needle. Okay, so additional procedures for thoracic ultrasound guidance. You can also use it in a thoracoscopy, and this is just a way to identify a safe insertion point for the trocar. Transthoracic biopsy, you would just useful in guidance of the needle to mostly peripheral lung lesions, mediastinal masses, and pleural lesions, allowing you to evaluate Doppler and position and maybe use that needle guidance to direct the needle right at the area. They do say that transthoracic biopsy under ultrasound can be beneficial over CT because it allows for real-time evaluation of the mass, and it allows you to place your needle in the most echogenic or solid region, allowing for a better histologic yield. And then finally, lung abscess drainage usually is only used after conservative treatment and recommended if the abscess is over 4 centimeters. But again, it would just allow you guidance of your needle or catheter into the abscess under lifetime to make you more successful. So in summary, lung and pleural ultrasound can provide extensive information quickly, at low cost and high yield, which can drive immediate practitioner decision making. Diagnosis requires good sonographic technique and knowledge regarding sonographic appearances of pathology, as well as good sonographic and good understanding of sonographic physics and instrumentation. Most extensive use of sonography in lung and pleural evaluation can help support performance of invasive procedures, reducing the risk and improving outcomes for the patient. So thank you so much for joining me today, and hopefully that you can incorporate some of these into your practices and enjoy it and find good patient outcomes. Have a great day.